What is GFR? GFR, everybody knows, it is glomerular filtration rate. So whenever any plasma is going through the glomerulus, what will happen? The plasma is moving like this. Some of the substances are being filtered. Some of the substances are filtered in the Bowman's capsule. So this is the renal plasma flow, and whichever substances are being filtered, that gives us the glomerular filtration rate, the rate at which it is being filtered. What is the renal plasma flow? I will tell you the normal values. It is 625 ml per minute. We will see what substances used to measure them also. What is the GFR normally? It is 125 ml per minute. These are the normal values. See, 625 ml is going per minute, but only 125 is being filtered. That is the glomerular filtration rate. So, if I am able to measure the GFR, I should choose a substance which is only filtered. There should not be any reabsorption or secretion. If it is reabsorbed or secreted, then only filtration cannot be measured. So, with the help of any substance which is only filtered, I can measure the GFR. So, depending upon the property of a substance, we introduce you to a term which is called clearance. What is clearance? With the help of clearance of different substance, we can calculate GFR, renal plasma flow, everything. What is clearance? It is the volume of plasma from which a substance is completely cleared off. From that particular volume of plasma, if the substance is completely cleared off, that is called as clearance. So how to calculate this clearance? This clearance formula is definitely an MCQ because it has been asked multiple times. So first, before going to the clearance formula, first let's try to understand it in a simple term. First thing is concentration. What is concentration? Concentration, all of us know, if there is an amount of substance, by the volume of substance will give me the concentration. Let's study with an example. I have some water bottle here and I put a 5 milligram substance inside it. And let's assume the quantity of this water bottle is 100 ml. So what is the concentration? Now tell me, what is the concentration? You guys will tell me that it is 5 divided by 100, which is 0.05 milligram per ml. For every ml, this much amount of dye is added here. So what we have done here, for identifying the concentration, we have put the amount of substances in the numerator and the total volume, that is 100 ml, in the denominator. But right now, we are trying to measure the volumes. We are trying to measure the GFR, renal plasma flow. These are volume of substances. So bringing the volume on the other side, the volume will be amount of substance by concentration of the substance. In this formula, there is again a catch. This amount of substance will be measured from the urine. How will you measure it from the urine? So the concentration of the substance in the urine by volume of urine flow. If I know the volume of urine flow and the concentration of a substance in that, that will give me the amount of substance. So instead of this amount of substance, I can substitute this, because directly I will not be able to measure how much of amount of substance is being released. So I take the concentration of substance in urine and I will calculate the volume of urine flow in the particular patient. That will give me the amount of substance. Then what is this concentration? This concentration is the concentration of substance in the plasma. That can be taken with an IV sample. So now you have to collect the urine and find the concentration of the substance and multiply it with the urine flow. Then for the plasma concentration, we take it from the arterial sample or venous sample. Now this gives us the complete formula of clearance. This final clearance, the formula is UV by P. This will be a MCQ where you will get all the values. You just have to plug into this formula and calculate it. So first UV is concentration of substance in urine, then volume of urine flow. This will give us nothing but the amount of the substance. This will give us nothing but the amount of the substance. Then finally divided by the concentration of substance in the plasma. So if I know all these values, then it is very easy for me to calculate the clearance. And if the substance is only filtered property is there, then what it will give me? This clearance formula will give me the GFR, because if a substance is only filtered, neither reabsorbed nor secreted, then that is GFR, because only filtration is happening and I am measuring it. That is the GFR. So let's try to understand how this GFR is measured and what are the substances used to measure them. First substance, which is the gold standard for it, is inulin. The substance is called as inulin. This inulin is the gold standard because whenever they did this method with inulin, the value for GFR came out to be 125 ml per minute, which is the exact normal value that we calculated from other studies also. So this inulin is the substance gold standard. But what is the disadvantage with inulin? Inulin, we have to inject it from the outside. So all the complications of dye being injected will be there present in the inulin. Is there any other method which is used? The second method is creatinine clearance. Creatinine clearance. This creatinine clearance has some advantages also and has some disadvantages also. What is the most important advantage? This creatinine is produced by the body itself. I am not going to inject anything into the body. This creatinine is already produced by the body. So it's an advantage. It is endogenously produced. It is endogenously produced. And what is the disadvantage? Whenever there is an advantage, there should be a disadvantage. And we know that this is not a gold standard also. So what is the disadvantage? It overestimates. There is some secretion which is happening, which is going to overestimate the GFR a little bit. Whenever the creatinine clearance was done, it was coming out to be 140 ml per minute, the GFR. This overestimation is the demerit for the creatinine clearance. That's why inulin is the gold standard, but creatinine clearance is a better method only. Why? Because there is an advantage of endogenous production. So nowadays creatinine clearance is used and they have some corrections for it to bring it to the normal values, like to the standard values. Then coming to the renal plasma flow. Renal plasma flow is measured using a particular substance which is called as PAHA, P-A-H-A. What is this PAHA? PAHA is nothing but para-amino hippuric acid. Para-amino hippuric acid. So these terms are very, very important. So whenever we are able to identify the clearance of PAHA, it will give me the renal plasma flow, and it's usually higher than that of creatinine clearance of creatinine, which is usually more than that of creatine of inulin, which is more than that of clearance of sodium, which is more than that of clearance of glucose. So this order has also been asked. So this order also has been asked. So clearance of PAHA is giving me the renal plasma flow. What is renal plasma flow? 625 ml per minute. This clearance of inulin is giving me what value? This clearance of inulin is giving me the GFR, which is 125 ml per minute. Then clearance of sodium, glucose, it is usually completely cleared off, but it is because it is completely reabsorbed for a normal individual. We are not talking about a diabetes patient. In a normal individual, it is completely reabsorbed from the kidneys. So that's why the glucose is at the last. So this order also you should know. Then coming to the another term, that is filtration fraction. Fraction means how much percentage of the total renal plasma flow is filtered. How will you identify? It is GFR by renal plasma flow. That is 125 by 625, which gives us 0.2, which means that 20%. The 20% of renal plasma flow is our GFR. So that is the filtration fraction. So this brings us to the measurement of GFR. So these all things are the things that is used to measure GFR and renal plasma flow. You have to remember all the substances. So coming to the determinants of GFR, GFR is determined by Starling's forces. It is determined by Starling's forces. This is the same Starling who has identified the Frank Starling law also, Starling's forces. So what is this Starling's forces? Let's try to understand. So whenever any blood column or fluid column is there and it has some proteins, what will happen? There will be some pressure caused by the water. Suppose if there is a tap, the water is there inside, it is causing some pressure on the tube. In a similar manner, the water molecules will cause some pressure on the tube, which is called as hydrostatic pressure. This pressure is hydrostatic. This pressure is moving the fluid from the inside to the outside. And there are some proteins which are present in the blood column. What they will do is they will cause something called as oncotic pressure. They will cause an oncotic pressure. So what is this oncotic pressure? Oncotic pressure means the proteins, they will move the fluid towards them. That is, they are sucking in the fluid from the tissue. So that is the oncotic pressure. So these pressure will be present in the glomerulus also as well as the Bowman's capsule also. So when I take the sum of all of this, that will give me an end pressure, which is also called as net filtration pressure. So let's try to understand how much pressure is being activated in each places. So coming to the hydrostatic pressure of the glomerulus, the hydrostatic pressure in the glomerulus is very high and it contributes to around 60 mm of Hg. So we will write it down here also. The hydrostatic pressure of the glomerulus is around 60 mm of Hg. It is pushing the fluid away from the glomerulus. Whereas the oncotic pressure of the glomerulus, it is pulling the fluid towards the glomerulus. It is around 32 mm of Hg. So the oncotic pressure of glomerulus, just write it down, just 32 mm of Hg. Now the same pressures also will be there in the Bowman's, which is also causing the same effect. So from the Bowman's, some hydrostatic pressure is putting the water out. So that hydrostatic pressure is around 18 mm of Hg. Hydrostatic pressure of the Bowman's is around 18 mm of Hg. And what is the oncotic pressure of Bowman's? Is there any value? There is no value. It is 0. Now tell me, what is the reason for this? The reason is pretty simple, because in our first discussion itself we saw the proteins are usually not filtered. The proteins are usually not filtered because they are negatively charged. The proteins are usually not filtered, so we assume there might be a very little amount of protein, but we assume that there is no proteins for creating the oncotic pressure. So the oncotic pressure of the Bowman's capsule, we should assume it as 0. So which forces are acting together? So these two are acting in one direction, like they are pulling the fluid away from the glomerulus. Whereas these two pressures are pulling the fluid towards the Bowman's, away from the Bowman's. So what is the net filtration pressure? So we have to use 60 minus 32 plus 18, which is around 10 mm of Hg. So this 10 mm of Hg is dominated by the hydrostatic pressure. This 10 mm of Hg is the pressure which is causing this filtration to happen. This 10 mm of Hg is also called as net filtration pressure. And it is in which direction? It is towards the Bowman. That is the reason for the entire GFR. It is towards the Bowman. Coming to the regulation of GFR, it is regulated through a wide range of change in blood pressure. So it has three groups of regulation. One is the auto regulation, where the GFR regulates on its own. Then there is something called as glomerular balance. Then finally the resistance of the afferent and efferent arteriole also will determine the GFR. This resistance of the afferent and efferent arteriole is very, very important. We will try to understand why it is important, because constantly there is an MCQ being asked and most of the time students make the mistake. So first, coming to the autoregulation, which includes myogenic response and tubuloglomerular feedback. This tubuloglomerular feedback we already saw, because whenever the sodium load or the chloride load is increasing, what it is going to do? It is going to reduce the GFR. And among the sodium chloride load, which contributes maximum, whose effect is more impactful? All of us think it is sodium, that's why it is the wrong answer. It is the chloride. Chloride influence is more. If the chloride load is more, it will be sensed very nicely by the macula densa. It is sensed by our macula densa. Just tell me what is the channel here? The channel is NKCC. Don't forget these channels also. Before going to the autoregulation, this is a graph which shows the wonderful nature of GFR, how GFR is regulated. Here the blood pressure is plotted along x-axis. Blood pressure is the systemic blood pressure. It is plotted along the x-axis, and the GFR is plotted along the y-axis. They have seen whenever there is a change in blood pressure, what is happening to that of the GFR. What they found out is, so whenever the blood pressure was changing, initially it was increasing, but after, whenever the blood pressure reached 80, from 80 to 180, the blood pressure can change from 80 till 180, around 100 mm of Hg it can change, but still the GFR will be maintained at 125 ml itself. That is the beauty of GFR. It is constantly maintained at 125 ml per minute, even with the gross change in pressures. And after that, there is a limit for everything. After that, obviously the GFR is going to rise. So this is the area where the GFR is very nicely maintained through a wide range of pressure. And all the mechanisms that we are going to discuss plays role in it. Coming to the autoregulation. The autoregulation, first one, the myogenic response. What is myogenic response? It is a very simple response. Whenever there is an increase in blood pressure, so the GFR is going to increase. It is very, very simple. Because of the increased pressure, it is going. So what will happen? They will stretch the vessels. So this stretch of the vessels will activate a particular channel. This channel is called as stretch sensitive calcium channels. So it is basically activating the stretch sensitive calcium channels. So what will happen? The calcium from the outside, they will enter the endothelium of the muscles. So what will happen? There will be constriction of the, so this calcium will cause the vasoconstriction effect. Vasoconstriction, that it is going to compress the vessels. So whenever there is a vasoconstriction happening, what will happen? There will be a decrease in GFR. So there is a decrease in GFR. So it is, whenever there is a stretch, it is contracting it back and regulating the GFR. That's it. It is very simple mechanism. Now coming to the second mechanism, that is glomerulotubular feedback. This is not tubuloglomerular feedback. Tubuloglomerular feeds, tubular senses, then the glomerulus is going to do something. But here the glomerulus is the first one, then tubular feedback is happening. This is very simple mechanism. So whenever there is an increased load in the glomerulus, suppose the glomerulus is having increased load, what will happen? They will be filtered, and this can be increasingly reabsorbed by the tubules. It is increasingly reabsorbed by the tubules. So they can reabsorb it again. For example, if this is the glomerulus, here the tubes is there. So whenever more is being filtered, more can be reabsorbed. For example, let's take an example. Normally, this channel, there are around say 100 sodium channels, and there are usually around 80 molecules only. So 80 molecules will be there. So all 80 will be reabsorbed. For example, I am saying it doesn't happen in sodium. All 80 will be reabsorbed. But when this 80 increases to 100, what is happening? The load on the glomerulus is increasing. It is coming, it is filtered and coming. But I told you here we have 100 channels already. So what will happen? All the 100 channels will get activated. Now they can reabsorb everything. That's why this is called as glomerulotubular feedback. But this feedback, as I said in the example itself, it goes beyond a certain limit. Like for example, now it has gone to 150. Can it cope up? No. Even this glomerular balance has a limit. It's not like it is going to reabsorb whatever load you throw on it. Then it becomes infinity, like the person will not have any defect at all. So that doesn't happen, but still some feedback mechanisms are there which is preventing the excess load which can be reabsorbed. So the GFR can be maintained again. So coming to the third one, that is resistance in the arterioles. This is the most important one for MCQs. Of course, tubular-glomerular feedback is the most important one for feedback mechanism. But for MCQs, this resistance in arterioles is very, very important. So now what they have tried is, experimentally also they have done it, and in some disorders also, disease also, this happens. They have changed the resistance of the afferent arteriole, and they have changed the resistance of the efferent arteriole. And finally, they observed what is happening to the GFR. So first thing is, let's start with afferent arteriole, which is easier to remember. So afferent arteriole, what they did is, they did constriction also and dilation also. Whenever they did constriction, afferent arteriole constriction, if the afferent arteriole is constricted, what will happen? The flow itself is decreased. So what will happen to the GFR? There is a decrease in GFR. It is very simple, because afferent artery is the one which is supplying. If I constrict it here, what will happen? The flow itself will be decreased. So the GFR will be decreased. Whereas dilation, the dilation is also very simple. I just dilate the afferent arteriole. So what will happen? More blood flow will be there. More of GFR will be there. So there is an increase in flow. There is an increase in hydrostatic pressure. There is an increase in GFR. So afferent arteriole is very simple. You constrict it, GFR reduces. You dilate it, GFR is going to increase. But when coming to the efferent arteriole, what happens is, first let's talk about the dilation, which is easier. First let's talk about the dilation. Whenever we dilate the efferent arteriole, what will happen? Now the resistance is not there. So what will happen? Whichever fluid is coming, they are not spending adequate time in the Bowman's capsule. Whatever fluid is coming, now they are going directly past to it, because now the caliber here is more. So there is no resistance. So what will happen? There will be a decrease in hydrostatic pressure. And all of us know that hydrostatic pressure is the one which is causing the net filtration fracture. Whenever there is a decrease in hydrostatic pressure due to the dilation of the efferent arteriole, what will happen? there will be a decrease in GFR. So it's very simple to remember. Dilation of the efferent arteriole, it is going to decrease the GFR. Now coming to the constriction of the efferent arteriole. The constriction of efferent arteriole is not so simple. The constriction of the efferent arteriole will vary the GFR according to the situation. So let's try to understand it very nicely. So efferent arteriole constriction. First thing is we are trying to constrict the efferent arteriole to very little amount. We are providing less resistance, so less than threefold resistance. So less than 1/3 of constriction of the vessel wall size. Here both are similar. The vessel wall size is being constricted to less than 1/3. So let's see what will happen whenever this much little constriction is done. So this is the afferent arteriole and this is the efferent. So whenever little constriction is caused, what will happen is there will be a back pressure here. So this back pressure increases the hydrostatic pressure. As you can see from the diagram itself, here the fluid is going to stay with increased pressure. So there will be an increase in hydrostatic pressure. Whenever there is an increase in hydrostatic pressure, what will happen to the GFR? The GFR will increase. The GFR will increase. And this is the one which is usually happening during physiological conditions. This is the one usually happening during physiological conditions. So for example, if the body wants to increase the GFR by itself, it constricts the efferent arteriole very little, not very much. If it does very much, it means that it is a disease, and we'll see what happens when the artery is constricted so much. Whenever there is a threefold increase in resistance, now we are increasing the resistance to threefold, or constricting the arterial lumen to more than 1/3. So what will happen? There is a severe vasoconstriction now. So what will happen? There will be a back pressure created. There will be back pressure created, and the flow itself is diminished now. There is a decrease in flow itself. Flow from the afferent arteriole is decreased. Then plus there is an increase in oncotic pressure because the proteins are constantly staying in the same place. Because of this constriction, what happens is the protein starts accumulating here. More and more protein starts accumulating here. When more and more protein starts to accumulate, there is an increase in oncotic pressure. So this increase in oncotic pressure will pull the fluid from here to the Bowman's. So what will happen to the GFR? There is a decrease in GFR. So whenever mild constriction of the efferent arteriole is done, it will increase the GFR. Whenever severe constriction is done, it will decrease the GFR. Just remember this fact.